In this section now we will discuss the diagnosis of acute bacterial meningitis. And in the diagnosis, we will talk about the diagnosis in immunocompromised patients who are immunocompromised, more prone to infections. Even the less virulent type of microorganism can cause serious infections in patients who are immunocompromised. So diagnosis in immunocompromised patients is very, very important that we should diagnose early. Then we will talk about the level of glucose in the cerebrospinal fluid, how it is in meningitis, and also PCR, polymerase chain reaction. And then we will discuss latex agglutination and MRI abnormalities associated with bacterial meningitis. So first, the diagnosis, the obtaining blood culture is very important to find out the exact causative organism that is causing the infection. So blood culture, then we have the empirical antimicrobial therapy. Before getting any culture results, the therapy we start with depending on the common causative organisms of the meningitis. Then adjunctive dexamethasone therapy, examination of CSF is very, very important to find out the meningitis. So cerebrospinal fluid examination, the level of glucose, level of protein in the cerebrospinal fluid, culture of the cerebrospinal fluid. So very, very important in the diagnosis of meningitis. Obtain neuroimaging studies like CT scan and MRI. So these are some initial diagnostic steps in the meningitis. Blood culture, beginning of the empirical therapy, adjunctive dexamethasone therapy, then we have CSF examination, and then CT scan and MRI. Next, the diagnosis, especially in the immunocompromised patient, no known history of head trauma, perform lumbar puncture. Lumbar puncture, if delayed, start empirical antibiotic therapy few hours prior to lumbar puncture. Gram staining and the detection of bacterial nucleic acid by polymerase chain reaction. So it's important that we should do the lumbar puncture. If lumbar puncture is delayed, we can start the antibiotic therapy. Lumbar puncture is the procedure that is performed to remove the cerebrospinal fluid between lumbar 3 and lumbar 4. We use the long needle to bring the fluid out to examine it for different changes. Antibiotics used in empirical therapy. Now the aim is usually to use the antibiotic that is most effective against the most common causative organism. So the aim is mainly we have indications and antibiotics. Preterm infants to infants less than 1 month, we use ampicillin and cefotaxime. From 1 to 3 months, again, ampicillin plus cefotaxime or ceftriaxone. Immunocompetent children more than 3 months and adults less than 55 years of age. Again, cefotaxime, ceftriaxone or cefepime plus vancomycin. So these are some common antibiotic therapies used, and if you notice, cephalosporins are very commonly used like ceftriaxone, cefotaxime. Adults more than 55 in adults of any age with alcoholism or other debilitating illness, we use the ampicillin plus cefotoxime, ceftriaxone, cefepime, and vancomycin. Then hospital-acquired meningitis, nosocomial meningitis, post-traumatic after the trauma, after any surgery, in patients who are neutropenic, low in white blood cells with impaired cell-mediated immunity. So we use ampicillin, vancomycin, ceftazidime, or meropenem. These are some antibiotics commonly used depending on the age of the patient. We select the antibiotic therapy. Next, cerebrospinal fluid abnormalities in meningitis. These are some very, very common abnormalities of cerebrospinal fluid, and the examination of the cerebrospinal fluid, if we find these abnormalities, the first indication is that this patient might have meningitis. So opening pressure is usually more than 180. White blood cells, 10 per microliter to 10,000. Neutrophils usually are predominant. Red blood cells absent in non-traumatic TAP. Glucose less than 2.2 millimole per liter or less than 40 milligram per deciliter. So glucose is less than 40. Cerebrospinal fluid serum glucose ratio is less than 0.4. Protein is increased more than 45, so low glucose, high protein. Gram stain positive in more than 60%, culture positive in more than 80%, latex agglutination may be positive in patients with meningitis due to Streptococcus pneumoniae, Neisseria, Haemophilus influenza, E. coli, group B, Streptococcus. So latex agglutination is positive in these cases. Limulus lysate positive in cases of gram-negative meningitis. Polymerase chain reaction detects bacterial DNA. So these are some abnormalities present in the cerebrospinal fluid which is removed from the patient with the meningitis. Next, the glucose concentrations, abnormal levels, if it's less than 2.2 or less than 40 milligram per deciliter. Zero in bacterial meningitis, CSF serum glucose ratio correct for hyperglycemia. So patient who have hyperglycemia, usually you get the wrong measurement, so it should be corrected and it can mask the diagnosis of the meningitis. So abnormal levels are less than 40 milligram per deciliter. It's zero in bacterial meningitis. Low levels when CSF serum glucose ratio is less than 0.6. Ratio less than 0.4 suggests bacterial meningitis. Reaching equilibrium takes time, D50 administered prior to lumbar puncture. So these are the levels which are significant of bacterial meningitis. Ratio of the CSF and serum glucose level, and if the patient has hyperglycemia, we might get the wrong result that can make the diagnosis bad. Broad-based bacterial polymerase chain reaction, PCR. 16S RNA conserved sequence detects small numbers of viable and non-viable organism, diagnosis in those who are, so this we are talking about the polymerase chain reaction. It can detect when there is small number of viable and non-viable microorganisms are present, and patients who are pre-treated with antibiotic therapy, gram stain is negative, CSF culture is also negative. So it is used in patients who have cultures are negative, and those who are already treated with antibiotic. Polymerase chain reaction is effective in diagnosing bacterial meningitis in these patients. Detects range of organism like Streptococcus pneumoniae and is positive. Latex agglutination test replaced by CSF bacterial polymerase chain reaction assay. Detection of bacterial antigens of Streptococcus pneumoniae, Neisseria, Haemophilus influenza, Group B, Streptococcus, and E. coli. So it's all latex agglutination detects all the antigens which are present in these infections. CSF latex agglutination test is specificity of this test is 95 to 100% for Streptococcus pneumonia and pneumonia. So very, very effective CSF latex agglutination, in which the CSF is tested for especially the Streptococci and Neisseria. The sensitivity, how sensitive it is, 70 to 100% for Streptococcus pneumoniae and 33 to 70% for meningitis. So Neisseria meninges. So all these are the different tests which are helpful in the diagnosis. CSF latex agglutination test is very effective for Neisseria and Streptococcus pneumoniae. Next, Limulus amoebocyte lysate assay. So Limulus amoebocyte lysate assay test is a rapid diagnostic test, detects gram-negative endotoxin in cerebrospinal fluid, which is helpful in the diagnosis of gram-negative bacilli. In diagnosis of gram-negative bacterial, the specificity of this test is 85 to 100%, and sensitivity is 100%. So a lot of tests are available which can detect the infection caused by Streptococci and Neisseria. They have a high sensitivity and specificity. False positive results may occur. Some other diagnostic techniques, we have MRI, which is preferred over the CT scan, demonstrate areas of cerebral edema and ischemia, diffuse meningeal enhancement is seen after gadolinium administration, not diagnostic of meningitis. So these are some other CT and MRI can be done, which tells us the areas of edema and ischemia present. Biopsy of petechial skin lesions reveal organism on gram stain, because we know that Neisseria meningitis, meningococcemia cause the skin lesions. So on CT we can see the areas of cerebral edema and ischemia. Differential diagnosis is viral meningoencephalitis, herpes simplex virus encephalitis, and the features of herpes simplex encephalitis is headache, fever, altered consciousness, focal neurological deficits, and seizures. So very, very closely related, the bacterial meningitis and the viral encephalitis, humans herpes simplex virus encephalitis, very, very closely resemble until we do some other tests to differentiate. Also, the differential diagnosis distinguishing test to differentiate is finding on CSF studies, neuroimaging, electroencephalogram. Viral CNS infections, like we can check by lymphocytic pleocytosis, normal glucose concentrations. Bacterial meningitis, we have polymorphonuclear pleocytosis, hypoglycorrhea. These are the some tests we can do, or the differentiating features between different infections, between the viral CNS infection, lymphocytic pleocytosis. Normal glucose concentration is in the viral infection, but in the bacterial it's different. And then we have pleocytosis, polymorphonuclear, and hypoglycorrhea. MRI abnormalities not in case of uncomplicated bacterial meningitis. Herpes simplex virus encephalitis, how we can check by the flare, diffusion, weighted images, high signal intensity lesion, and distinctive periodic electroencephalogram pattern. Rocky Mountain spotted fever, again it is transmitted by the tick bite caused by Rickettsia rickettsii, present with the fever, prostration, myalgia, headache, and nausea and vomiting. Now this especially we need to differentiate with the meningococcemia, because that is also causing the rash, but this is caused by the tick, which is Rickettsia rickettsii, that is caused by the Neisseria meningitis. Also there is high fever, myalgia, nausea, vomiting, headache, and you can see the rash. Rash initially diffuse erythematous maculopapular rash, so it comes in the differential diagnosis of meningococcemia. The Rocky Mountain spotted fever progressed to petechial rash. Purpuric rash, untreated, can cause necrosis and the gangrene. Rash begins in the wrist and ankle. Here you can see it begins in the wrist and ankles, spread distally and proximally. Diagnosis is by the staining of skin biopsy specimen. Then we have another condition, ehrlichiosis. This is also transmitted by the tick bite, small gram-negative coccobacilli, Anaplasma phagocytophila. This causes anaplasmosis. Then we have Ehrlichia schiffensis, causes human monocytic ehrlichiosis. So all these are different differential diagnoses we are talking about, which can be differentiated from the condition like meningococcemia. So we have ehrlichiosis, which is caused by the tick bite, and this is by the small gram-negative coccobacilli. Then we have anaplasma phagocytophilum, which cause anaplasmosis. Maculopapular or petechial rash, increased level of LDH, ALT, and alkaline phosphatase. So that's also a differentiating feature. There is increased level of LDH, alkaline phosphatase, and transaminase. Focal suppurative CNS infections, we have like subdural and epidural empyema, presence of abscess or pus in the subdural and epidural space. Brain abscess, MRI performed promptly, those with focal features. Detection of intracranial infection and infection in sinuses or mastoid bone by the MRI. Next, non-infectious CNS disorders which mimic the bacterial meningitis. We have subarachnoid hemorrhage. Subarachnoid hemorrhage as a result of increased blood pressure. There is rupture of the blood vessel and there is hemorrhage. Very, very closely resemble the meningitis. So subarachnoid hemorrhage. Chemical meningitis, drug-induced hypersensitivity meningitis, carcinomatous or lymphomatous meningitis, meningitis associated with inflammatory disorders, pituitary apoplexy, and then we have uveo-meningitic syndrome. So these are some non-infectious disorders that can mimic the bacterial meningitis. Then in this consideration of subacutely evolving meningitis. Principal causes are Mycobacterium tuberculosis, Cryptococcus neoformans, Histoplasma capsulatum, Coccidioides immitis, and Treponema pallidum. So all these are the other factors that can cause subacutely evolving meningitis. So that was all about section 4. Thank you for watching sqadia.com.